Please remember that donor is going to be with you and he's going to be there for another 2-3 years. These transplants are not urgent. You can do them 2-3 years later when the donor is old enough to donate a product as well. And there's unrelated. I'm not going to touch the related story. Even in the related umbilical cord blood, most of the data is with very low risk patients. The rejection rates are in the 10-20% range, which is fairly high. Okay? And one would argue that these donors are with you, they're not going away anyway. The unrelated cord blood transplant, I'm sure things will change, but the existing data is quite depressing. And in fact, the patients who are alive and disease-free in a large study was only 23%. So at this point in time, I think there's fair consensus that unrelated cord blood transplant is not an acceptable standard of care for thalassemia major. Of course, we want to increase the pool of donors that are available for thalassemia major, and there has been remarkable changes both in this country and the world with unrelated donor transplants being done in many centers in the country, including haplotransplants being done in many centers. The initial data prior to high resolution typing was not so good, but including the previous data that I showed you from Locatelli in children, the data has dramatically improved in unrelated donor transplants. And most people will tell you that there is not that much of a difference between unrelated matched transplants and a related sibling transplant, marginally probably less. In fact, if you look at this EBMT data, which is a large retrospective analysis of almost 1,500 patients, what's very interesting is a mismatched family donor is worse than a fully matched unrelated donor. Okay, so we often take up patients, who are one antigen mismatch, grandfather, cousin. You actually are putting that group in probably a slightly higher risk than having a 10/10 fully matched donor. Okay, so in fact, with unrelated donor, and there is published data to that the better the level of match, at our center, we would insist on a 10/10 match if we are going with a conventional conditioning and GVHD prophylaxis regimen. Haplotransplant, again, evolving data. There's some very interesting data from the Thailand group where they use the concept of pre-transplant immune suppression and then do a transplant and post-transplant cyclophosphamide. That data is quite good when you do, and there's also data with CD3 alpha beta depletion, which is also very exciting and evolving, and these things I'm sure are going to become fairly standard. But at this point in time, I don't think we can call it standard of care, though the data is definitely exciting. I'll stop here by just saying post-transplant issues for ex-thalassemics. You must remember that post-transplant, everybody talks about the neutrophils, and I did not highlight the graph that I showed you because of time constraints, but your CD4 takes almost 2 years to hit back normal. Your CD8s and your NK cells come back much faster. So your immune system is highly compromised. You cannot expose these people to live vaccines, okay? Remember that transplant doesn't solve the problem continuously. All the years that he has been transfused, he needs chelation for almost that many years to get him back to a normal chelation level. Otherwise, the existing iron is going to continue to do liver and gonadal damage. Very important. Very difficult to convince patients sometimes to be regular on their chelation and venisections post-transplant. Monitor growth endocrine evaluation, very important. There is no diet restrictions. Marriage counseling is important, though many of these patients are likely to be infertile, okay? But they could have children, and it's very important to remember that when you transplant, you change the phenotype of their hematopoietic system. You've not changed their gonadal cells, okay? And they still carry the thalassemia mutation. So if they have children, they marry somebody who's a carrier, they can end up with thal major as well, okay? So this is just two families. One of them, both, a sister and a brother. One of them is the donor, one of them is thalassemics, more than almost 15-20 years post-transplant. Not for anything, just to tell you that by looking at them, it's almost impossible to say who's the patient and who's the donor. So when it does go well, it's a very satisfying and very, gratifying to have these patients come for you to follow up. I think I'll stop there. Happy to take any questions. I hope I kept in time, BIJU.
Thank you, Vikram. So now the floor is open for any questions that you would like to ask.
Excuse me, sir. Ideals C34 count for the thalassemia?
C34? Yeah, so the conventional answer is between 6 to
9 million, and you generally try not to go beyond 9 million. Okay, so that's the kind of a standard that we try to use. But I would err more on the 9 to 10 million than on the lower side.
For the age cutoff, for a well-chelated 20 years, no hepatosplenomegaly, ferritin is less than 1000, full match donor, suddenly they realize that now I'll go for transplant. Age is 25. So what do you say?
I would offer transplant if they understand the risk. You must also remember the caveat in all the risk stratification, it does not include adult patients. So once you're over, what's the definition, 2021, you're really not, this classification probably doesn't apply, and you are straight away a slightly higher risk group of patients. But as you say, very well chelated, no liver, no fibrosis, there's absolutely no reason to believe that he's going to be under any higher risk.
So if we have to counsel this kind of patient, what should we counsel, like about the risk and long terms,
I would say in the patient that you defined, he has an almost 78% chance of having a thalassemia-free soil.
The source of the bone, do you use peripheral stem cell in thalassemia or just stick to bone marrow?
No, so my apologies, I didn't touch on that. When we use the thiotepa trio based on our mixed mechanism, we do use a PBSC. That is not standard of care by many people. We still stick with BIJU and a bone marrow for our class 1, class 2 patients. But for the thiotepa, when we're using class 3 and class 3 high risk, we are really concerned about rejection. We don't want rejection. And for that group of patients, we would use a PBSC. So the published data is, the acute GVHD is not too much. The chronic GVHD is definitely there, but for the most part it's limited, and a small proportion of patients have extensive chronic GVHD.
Any further questions? If not, thank you, Vikram.
The next speaker is Dr. Sunil Bhatt. So after finishing his post-graduation in pediatrics, he did his fellowship in pediatric hematology oncology in New Delhi and followed away in Sydney, Australia, another fellowship. To add to the cap, he did his advanced fellowship training in the BMT in Sydney, Australia. That is currently in head and senior consultant in pediatric hematology oncology and BMT in Musumdar Cancer Center, and is a young dynamic person. We all know that usually pediatric training in the transplantation settled mostly in the North India, and to be in South India, we all know Dr. Revaridaj is the one unique, and for all of us to know that, to pinpoint, to compare everyone, and now he is challenging from another spectrum. Yes.
I think it's daunting to be sandwiched between Dr. Vikram and Dr. Revati, so I think it's not just. Thank you very much, Dr. Kishore, for having us here. And although the topic was transplanted primary immunodeficiency in children, I just wanted to because I thought it's mainly student audience, so we thought we'll just have a little bit brief about the genetic disorders as well, excepting hemoglobinopathies and bone marrow failure syndromes. So I think this was made clear this morning. We are not talking about any other stem cells. We are talking about only hematopoietic stem cells, and there are a whole lot of other stem cells which are predominantly what we call mesenchymal stem cells. We're not talking about that. We also talked about, I think earlier it was discussed, how to choose a graft, whether a marrow graft or a cord blood graft or a bone marrow graft. What will you choose? And I think it's based on the composition of the graft, and also the what we expect for the graft to do, whether you want any graft versus leukemia effect and how much graft versus host disease can you tolerate. So I think the thumb rule is, in a non-malignant setting, you don't want GVHD, you want to go with a bone marrow graft. In a malignant setting, you want the graft versus leukemia effect, and so you want to go with the PBSC graft. Now going on to the topic, so I'm just starting the case presentation just to give you a little bit of a taste of the immunodeficiencies, and then we're going to discuss a little bit more about them. This was a 1.5-year-old boy, not gaining weight, multiple swellings all over his body, abdominal distension since the age of 6 months. Secondary consanguineous marriage, the only living child in the family. 2 elder siblings had similar complaints and had BCG tendinitis and died of those at the age of 6 months. Fortunately, this child was not immunized for BCG because of the past history in the family. He was aged until 9 months of age, and then started developing recurrent pneumonias. As we would do most of the times in India, he was investigated and treated for anti-tubercular medications. There were no response. Had a good appetite, but he was not able to thrive in spite of a good appetite. This is the patient when he came and to see us. He was pale. There was generalized lymphadenopathy all over his body. What was very characteristic, so there was characteristic rash, which was erythrodermic, ichthyotic rash all over his body, and there was hepatosplenomegaly. So we tried to evaluate him, routine investigations for tuberculosis, inborn congenital infections. We couldn't find anything there. What was startling was his total count was quite high. We ended up doing a liver and a lymph node biopsy to find out the cause for his organomegaly lymphadenopathy. There was nothing there as well. But what we saw that there was a lot of proliferation or infiltration of these of liver and lymph nodes with normal-looking T lymphocytes. Primary immunodeficiency was high on the cards because of the prior history and the presentation in the child. Chronic granulomatous disease, leukocyte defects would be the causes which will fit in this, and you try to look for those. They were normal. His immunoglobulin levels were normal. We ended up sending T and B subsets, which again were normal. But when we looked at the T cell functions, and this was done at NIH Mumbai, Dr. Manisha did it for me, the T cell proliferation was not normal. So his T cells were normal in number, but they were not proliferating to a stimulus, which was CD3 and CD28 stimulus. They were not proliferating to that. So based on this, we made a diagnosis of T cell functional defect. We know these numbers are okay, but the T cells are not functional. And although at this point of time, we didn't know the genetic lesion for his pathology, why his T cells are not functional, we didn't know. But we did realize that a bone marrow transplant may be the cure for this patient. There were no siblings. He was the third in the family. The previous two siblings had died. No one in the family to donate. There were no unrelated donors available for this child. And we ended up selecting one of the parents as a donor, because at this point of time, I didn't know the inheritance of this genetic disorder for this child. So we ended up selecting father to be a little safe. What if it was an X-linked disease and the mother is the carrier of the gene? So we ended up taking father as a donor, and he had transplant using father's stem cells. Good engraftment on time, 100% donor comes on day 30, and then the same child still in the BMT unit around 1.5 months post-transplant is completely changed. The skin has resolved, organomegaly resolved, lymphadenopathy resolved, and now is about 3 years post-transplant and is well and cured of his disease. While he was getting worked up for the transplant, mother was pregnant, and she was pregnant by about 16 weeks. So they did discuss with us antenatal testing, but because we didn't know the genetic lesion at that point of time, we couldn't offer that. So we did explain to them the risk of continuing the pregnancy. Because we didn't have anything else to offer, the family chose to continue the pregnancy. And the baby was the fourth baby. The next baby after this was born. Because we were quite kind of suspicious with the next baby, we worked him up early. And as destiny would do, the fourth one is also affected with the same problem. He got the stem cells from father as well and cured of his disease as well. We had taken, because he's a small baby, so we had enough cells stored with us, cryopreserved, and was treated with the same stem cells from the father and cured of the disease. Now, before transplant, his blood was stored, although we didn't know the genetic lesion, but the blood was stored. And one of the labs in Bangalore helped us with doing the next-gen sequencing on that blood sample. And what we identified that this child had a mutation in the interferon gamma receptor 2. And that was the pathology behind the whole T cell functional defect in this child and also of the family, and would explain the phenotypic manifestation in this family. Autosomal recessive, but it was just quite I would say unfortunate that all the children back to back had had manifestation of the disease. So this is just a case to highlight that we need to with better diagnostic modalities, with high rates of suspicion, we can pick these children. We can pick the children and cure the children, and that's how we can make difference in the life of these families. Now, transplant, as we know, I think it was one of the MCQ questions we had earlier today, one of the quiz questions. It's not an early, it was started in 1956, 57 on a patient with leukemia. There's a lot of pediatric, I would say, history. The first patient who had transplant ever was a pediatric patient for leukemia. The first non-malignant transplant was done for again a pediatric patient for severe KUMAR mutation in 1968, and that was done by what we call as the father of immunology, Dr. Robert Good, and that set the kind of the pace for non-malignant transplants. After that, 1968 was the first skin transplant performed. Now, indications of allogenic transplantation, I think we have discussed them by bits and pieces, but it's broadly malignant, which is leukemias and lymphomas, and non-malignant. And non-malignant is a big basket of disease. I think Dr. BIJU mentioned earlier about 30 to 40% transplants done in India or maybe elsewhere as well are congenital disorders, and immunodeficiency is a big group. Also hemoglobinopathies, which is sickle cell, thalassemia, bone marrow failure syndrome. These we're going to discuss a little bit later on in detail, and storage disorders. I briefly touch on these as well because it's again a group of disorders. Acquired disorders, aplastic anemia, paroxysmal nocturnal hemoglobin. This is not extensive list, but this is just a flavor of what are the conditions which allogenic transplants work. Now, the principles of transplant is broadly three: high dose chemotherapy and dose response curve, which we